All right, everybody, we're back, 9:55. I don't think there's any questions I need to respond to, so I'm just going to move on and hand the microphone over to Dr. Z. So let me get his screen pulled up here. Let me get that off. There's his screen on your screens. And I'm going to hand the microphone over to Dr. Z. Here you go, Doc.
Thank you. Hey everyone, this is Dr. Z, one of the residents over at Freeman. You guys probably see me. I'm the Asian doctor that's walking around. All right, so I'm going to be talking about some pretty common ingestions that you guys might see, toxidromes, just what to kind of look for, and that would be helpful for us once you bring him into the emergency department. A lot of this has to do with history, honestly. You guys get a good history from what's been going on, maybe family members, things like that, or just what the situation is. It's actually usually very helpful. So the history is a big deal here. So this is something that we get from our training here. A lot of the times it's really ABCs that are most important. If these drugs are doing anything to people, you really want to look at those ABCs. And I think I gave the training chief over here at Met Scotty here the copy of my presentation. So if you guys want to look through some of these things for just some of the really high points, you can definitely get a copy of it and then just review it yourself. So here, the mainstay for you guys is definitely ABCs, airway, breathing, circulation. A lot of times, some of these medications can also affect the heart. So it's not a bad idea to get an EKG, as it's noted right there. If they have any sort of depression, they look kind of altered neurologically, you can always get a glucose. That's always appreciated for us too. And that can sometimes key you in on what's going on. As well as their temperature. If they feel really hot, that's definitely something to pay attention to. So your vital signs as well as history, just a lot of those real basic things, they're actually super high yield, which is why they're so important. And then we'll go through some of these things about clinical presentations, like they talk about bradycardia with the channel blockers, hypotension as well, the QRS, and sometimes the long QTs. And we'll go through that some more. A lot of that stuff in the lower part, using activated charcoal, I'll talk about a little bit. But, we're not going to alkalize the urine in the rig or anything like that. At least that wasn't what I did when I was in EMT. But, maybe you guys got some special tools nowadays to do that stuff. All right. So the first thing is acetaminophen. How much is too much? So, it's always important to ask how much do you think they took? And, doing some quick math with your phone or something like that can be very helpful. Typically, we see elevated liver function enzymes in the ED. So we use that as well as how much they've taken and how long ago to kind of calculate how much we need to treat. The antidote is NAC within 8 hours. So I don't know if the rigs have any NAC, but within 8 hours, that's a key window. So if you guys are able to get us that information, and which you guys typically do very well, like I said, that history of how much you took, when you took it, super important. And if you guys do have the NAC on board, then you can give them that sort of loading dose at first. And they have a lot of other NAC that you have to give over 24 hours, but we don't even do that in the emergency department, so I'm not going to bother you guys too much with that either. And then if you don't know, it's always okay to give NAC. In fact, they even say NAC is a treatment potentially for COVID now. One of the attendings in the ICU was just talking about that today. Next is aspirin. Sometimes you might hear someone say oil of wintergreen. So you have toxicity levels as well. So you've got acute, which is 150 to 200, and 300 to 400 is serious. Those are usually lab values that we get. But also something interesting is that maybe they didn't just take a huge dose to try and overdose right then and there. It could be chronic as well, and that's as short as 2 days. So if they've been kind of overdosing a little bit, saying, I have a horrible headache and I've been taking a ton of aspirin, that can also be pretty toxic. Symptoms that you might see: vomiting, bleeding. They might say that they have ringing in their ear, which is that tinnitus, and they'll have lethargy. You'll get this sort of respiratory alkalosis, metabolic acidosis. So you'll see them with low CO2s if you attach the monitor. And they'll also get hypoglycemic. So you can use activated charcoal, but there's no real antidote for aspirin. So talking about metabolic acidosis with an anion gap, there is a med school mnemonic that we use for what it is, what drugs can cause it. So on the left, you see it's A, mud piles, alcohol, methanol, anything with urea, diabetic ketoacidosis, paraldehyde, iron, isoniazid, lactic acid, ethylene glycol, salicylates, starvation. That's a long list. One of my mentors when I was in medical school said, you want to simplify it as much as possible. We're not internal medicine docs. So he was an EM doc, and he said just CULT. So anything that causes ketones, like DKA, alcohol also causes ketones. Any of those alcohols, really. Any sort of thing with uremia, anything that causes lactic acid, such as, someone's septic, and then any sort of toxins that you're concerned of can also cause metabolic acidosis. So that's a lot easier for me to remember, at least. So speaking of alcohol, typically it's really just supportive care. You'll see a lot of times they get hypoglycemic. But there are also a couple other different types of alcohols that we have to consider, especially for those lushes out there who they'll drink anything and anything to, get drunk. So you got methanol, which is that windshield wiper. As little as 40 milliliters can kill them. They'll usually say that they can't really see. They'll say it's some sort of a snowy sort of gaze. Looks like they're in a snowstorm or something. So it creates fromate, which is more for the residency to talk about, since I'm going to give this lecture as well to them. And then you'll have that elevated anion and osmolar gap. Then you've got rubbing alcohol, which you'll get that ketosis, those ketones, but they won't have acidosis. And lastly, you'll have antifreeze as well. Antifreeze, the main thing that you guys would probably want to watch out for is that prolonged QT, because it causes hypocalcemia. And then it forms these oxalate crystals, which will make the urine actually light up if you use one of those special lights. But the main thing for that ethylene glycol, if they've been drinking antifreeze, a good thing to do is to definitely check that QT. Next, we got beta blockers. So, old people, sometimes they take too many of their beta blocker pills, something like that. So obviously, beta blockers slow down your heart rate. So you get Brady, but you can also get hypotensive. And the main thing for beta blockers is you get hypoglycemic. So the main thing you want to take a look at is, once again, that EKG. It's supportive therapy, and you do ABCs. So if it's mild and you're concerned, you can just do 1 milligram atropine. So when does this not work sometimes? Well, atropine has to do with the nerve stimulation. So if they have like a heart transplant or something, atropine's not actually going to work. So you can switch over to epi, norepi, dopa, isopril. The first line treatment is actually glucagon if you've got it on the rig. And then funnily enough, too, you can give them insulin, which is the opposite of glucagon. So insulin and glucose. So that's also, kind of ties into that hypoglycemia. They're not getting enough glucose, so you give them glucose, but you also need them to use the glucose that you're giving them, so you give them insulin. So you can try the atropine, and then you can try glucagon, insulin, and glucose. And then intralipid, like I said, some of this is more for the residency, but beta blockers are pretty lipophilic, which means that they like fats. So you use that intralipid to kind of suck up all the beta blockers. Next, you got calcium channel blockers. So this presents very similarly to beta blockers because, once again, it makes sense because they're blocking the heart from beating really fast. But there is a key difference. You'll see that they're hyperglycemic. So calcium channel blocker kind of speaks for itself. What do? Well, you give them calcium, right? Makes sense because you got something that blocks the calcium. You want to flood those channels with more calcium. So you can give them calcium chloride, 1 gram, calcium gluconate, 3 grams. In peds, if it's a little kid, little kids love grabbing stuff and just eating grandma, dad's meds or something like that, 20 milligrams per kilogram. And like like beta blockers, you typically have to observe these because they've got some sort of extended release formulas and things like that. They might look okay, but then once it's absorbed, then typically we have to observe them in the hospital. Next up, we got clonidine. So similarly, you got bradycardia, hypotension, as well as CNS depression. You know, they might be acting a little goofy. They might be breathing a little bit. In fact, clonidine is actually, the way it's done, or the way the drug works, is that it's very similar to opioids. So you have decreased respiratory drive, meiosis, and we'll talk a little bit about opioids and meiosis. I've got a good mnemonic. But since it's similar to opioids, what's the treatment? Well, it's Narcan. So you can give them Narcan and hopefully kind of fix them up a little bit. Narcan usually lasts for about 30 minutes, so, you know, hopefully long enough for you to get them over to us. So other sort of alpha-1 antagonists, like I had mentioned before, hypotension, sometimes they can get syncope, which means fainting. And just always remember, worst comes to worst, just treat the vital signs and make sure your ABCs are good. If they're not breathing, intubate them. If they're bradycardic, you can put the pads on, try giving some atropine, make sure they've got circulation. Stick to the basics and typically you can't go wrong. Next up, we got these diuretic antihypertensives, like, you know, you got spironolactone, you got hydrochlorothiazide, people are taking Lasix at home, things like that. And these can really mess up a lot of your electrolytes. And because they're diuretics, which means that you're flushing out a lot of fluid, the concern is for hypotension, and sometimes they can get really sleepy with this. The main concern are those electrolyte derangements, which you're not really going to be fixing in the rig. But if they're hypotensive, you can always give them normal saline and just make sure that they're still breathing. They're not apneic or anything like that. And like I said, ABCs. So TCAs, these are those psychotic medications. They have a lot of effects, unfortunately. They block your sodium channels. They're anticholinergics, which I'll talk about. And they also inhibit adrenergic function as well. The big thing is to look at the EKG. You hear that they did a TCA overdose, you know, someone who's suicidal, who's on antipsychotic medication. They're like, I just wanted to end it all. I took all my antipsychotic medication. Look at that EKG. The QRS, how wide it is the most sensitive. Greater than 100 milliseconds, look at seizures. And then greater than 160, you got to start worrying about cardiac arrhythmias. So because it's blocking sodium channels, the treatment is actually sodium bicarb. So you can keep bolus pushing 1 to 2 milliequivalents until that QRS narrows. Or if you're in the ED, we'll typically check their pH as well. We try and alkalize that urine, which means we make the urine pH higher to 7.5 to 7.55. Yeah, amitriptyline, exactly. Nortriptyline, any of those triptylines you might hear, that kind of stuff. So opioids, you guys are super familiar with this. I have a little asterisk here, clonidine, just to remind you that clonidine, opioids, very similar. The treatment is Narcan. So we talk about meiosis, hypoxia. How I remember what that means, what does meiosis mean? It's got that O like opioids, and then I think of pinpoint with an O, so that means really small pupils, if you ever have problems remembering that. And you've got hypoxia, which means that they stop breathing. So you give them Narcan, and like we always talked about throughout this whole time, ABCs, ABCs, ABCs. You can't go wrong with those ABCs. Next up, we got the seizure medications. Someone takes benzos. Usually they themselves don't hurt you too bad, but it's those co-ingestions. You know, someone takes benzos and alcohol together. They're really trying to just, you know, have a good night or something. So primarily it's CNS depression. The treatment is flumazenil. So that's got a Z, just like benzos, flumazenil. So you can think about that. But the concern with benzos, especially if you give them flumazenil to treat it, is acute withdrawal that can cause seizures. So, you know, usually someone has seizures, you give them some benzos. But if you stop those benzos, people are more likely to actually get seizures because benzos are treating the seizures, but now you're kind of taking away those benzos, and they're more likely to get seizures because of it. You're taking away the benzos so quickly that they have a higher chance of getting a seizure. Next up, you got barbiturates. So they're very similar in mechanism. They're almost the exact same. They're very short acting most of the time. Typically, symptoms you'll see is hypotension. So like I said, ABCs. And you can prop them up with a bag of normal saline and decrease reflexes. Treatment, you can give them activated charcoal. And then you can give them sodium bicarb too. And there again, you see those pH goals that we do. Typically, you won't really do that in the rig. You can start sodium bicarb if you know for sure. I don't know if there's a protocol or something like that, but sodium bicarb and activated charcoal, I'm sure you guys have. Next up, you got phenytoin. So the amount of phenytoin that they've taken will cause certain symptoms. So the first thing you'll see is horizontal nystagmus. And what horizontal nystagmus is if you tell them to look to the right, they're looking to the right, but you'll see their eyes kind of flicker back and forth. Like they can't keep it in one location, and it kind of keeps, it looks like a beat. Like it beats trying to go back to the left. And then if there's more unsteady gait, slurred speech. So a lot of times these phenytoin drugs we use in the ED is actually through the IV, and that can be cardiotoxic. But if you see them out in the field, typically, they don't have IVs or infusions. I mean, some places might, but typically not for oral medication. You can do an EKG since it could potentially be cardiotoxic, but once again, it's supportive management and activated charcoal. So I've talked about a lot of activated charcoal, and there's a lot of indications for when to use it, but I think it's probably shorter of when not to use it. So you don't want to use activated charcoal when you're concerned that that person might throw up, because you're going to put all that medicine, all the drugs, as well as the activated charcoal in the lungs, and that just makes for a really bad time. Anything that's small ions, lithium, any of those small metals like iron and things like that, activated charcoal is not going to take up. Anything that's like bleach, any sort of acids, things like that, not going to work with activated charcoal. And hydrocarbons, those are like benzene rings that smell really fragrant. You don't want to use those. But like we had talked about, a lot of other drugs that don't really fit in those, you can use activated charcoal for. So the dose is whichever is bigger. So you got a big guy, then you can just use their weight. It's 1 gram per kilogram. Or 10 grams per gram of ingestion. So just an easier way to think about that is, how much did they ingest? You give them 10 times that amount. And that's how much activated charcoal you want to use. So we got some of those depression medications, those SSRIs, those serotonin reuptake inhibitors. So they could be bradycardic because of the serotonin reuptake inhibitors. Treatment, once again, like we always talk about, is typically supportive. There's this thing called serotonin syndrome, which happens very quickly once they start a new SSRI or something like that. That can cause myoclonus, diaphoresis, ataxia, which means that they walk funny. Myoclonus is hard to really test in the field, but based off your history, if they said that they just started some SSRIs or some antidepressant medications, you can check for hyperreflexia, test those reflexes, and the treatment is benzos. Something else that's very similar to serotonin syndrome is NMS, which is neuroleptic malignant syndrome. Instead of serotonin, this is from a dopamine deficiency. So it's malignant syndrome. Usually they have some malignant hyperthermia, which means that they're very, very hot. They run very hot. And the history is really what's going to key you in here. It's more gradual. So they'll be like, oh, I started taking some medication maybe a week ago, several days ago. Serotonin syndrome happens very quickly. I have sort of a mnemonic, which is like S. S is for speed, so it's very fast. Whereas NMS is sort of slow. It's harder to it doesn't really roll off the tongue either, so it's more gradual. The treatment for NMS is also benzos. So you got your sympathomimetics that we see a lot here. Cocaine, amphetamines, sometimes even caffeine, and then some over-the-counter drugs. People taking a lot of that cold and cough medicine with pseudoephedrine. So what's the difference between this and something like an anticholinergic that we'll go through later? Sympathomimetics, because they up your sympathetic nervous system, you will get sweaty. They'll be really, really sweaty. Unlike anticholinergics, where people can't pee, can't poop, it won't stop that. They'll actually want to pee. They'll want to poop. And then they'll still have reactive pupils. A lot of times in those anticholinergics, they'll have non-reactive pupils, but you won't get that. You'll still be able to shine a light and them to be reactive. So here, anticholinergic, the mnemonic that we have is mad as a hatter. So they're altered. Red as a beet, they're very hot. Dry as a bone. Red as a beet as in they're very flushed. Dry as a bone, which is the key difference between sympathomimetics like cocaine, amphetamines versus anticholinergics. Blind as a bat, they can't see at all because their pupils are so dilated. And then hot as a hare, they're very, very hot. Some other things that you might hear: nightshade, Jimson weed, mandrake, and henbane. So cholinergics, on the other side, it's the opposite. So this will cause people to have a lot of secretions. Sialuria, which means that they'll be kind of frothing at the mouth a little bit. Lacrimation, they'll be crying. They'll want to pee everywhere. They'll be pooping everywhere. They'll just have fluids from every single hole possible. So typically these are like insecticides, things like that. The treatment is to give them atropine. And when do you know when to stop? It's when those secretions dry up. So organophosphates actually, So organophosphates, typically you see these in farmers. Those are the insecticides. They're the exact same thing as those cholinergics. The treatment, once again, is atropine until those secretions dry up, and then you can give them pralidoxime, which is 2-PAM as well. So next up, we have some inhalations. This is just useful, especially for you EMS folk who, present to fires or something like that. You got some people who, especially with winter coming now, they might be using some at-home burners or something like that. Some of those gas burners, and suddenly, they're just saying they're not feeling well. What are you concerned about? So, carbon monoxide. Sometimes they'll say, I feel like I have the flu, but they don't have a fever. This is typically from gas leaks or even fires. Like I had mentioned, heaters. Especially if a whole family's living together and they're like, oh, we all came down with something, but we're not really coughing, we just feel bad. It could be carbon monoxide. You check their O2 set and it looks fine, but you still suspect that it could be some sort of like heater that's been giving off carbon monoxide or anything. And that's because you need to test it with a co-oximetry, which is a special little tool. I didn't have it on my rigs. Maybe you guys have it. Or we test it with serum carboxyhemoglobin in the ED, which is a blood draw. The treatment, though, is just to give them a bunch of oxygen. It's to flood them with oxygen, tons and tons of oxygen. Carbon monoxide can last in your body for like 240 hours if you don't give them oxygen, but it drops down to like 10 hours or something if you give them like 100% O2 via non-rebreather. So that oxygen is really important to fight against the carbon monoxide. Next up is cyanide. So typically you see this in fires. It's because the wood, the plastics, all that other stuff burns, and then it creates cyanide gas in the air that people inhale. Symptoms that you'll see is hypotension. They might have decreased consciousness. They typically will see in the ED, they'll also have lactic acidosis or a metabolic acidosis because the cyanide is blocking them from using their normal energy consumption. So it creates lactate as well. And sometimes these patients might even say that they notice a bitter almond smell. So the treatment is, first and foremost, you want to use this hydroxycobalamin. If you don't remember anything else, it's hydroxycobalamin. Some places, they'll still have these cyanide antidote kits. do not use anything that says nitrite in it. And the reason is because if you have cyanide poisoning in a fire, you could also potentially have carbon monoxide poisoning, and those nitrites that you give them will kill them. So you want to stay away from anything that says nitrite. You got sodium thiosulfate that you can give them in the antidote kit, and you got hydroxycobalamin. But if you're in a fire and you're concerned that there could be carbon monoxide poisoning as well, stay away from those nitrites, because that can actually make it worse and that can kill them. Next up is fosgene. So sometimes you show up at a farmer silo and they're like, I just feel awful. Feel like there's this like fresh cut hay smell and this white puff of smoke came up. This can actually be pretty severe, but they have delayed respiratory compromise. So you want to still bring them in, especially if they're concerned that they've gotten exposed somehow. But typically this is hours later. So you just want to support them while they're getting over to the emergency department. Once again, ABC is super important here. Especially if they have respiratory compromise, a couple hours later when they're feeling horrible. That's the main thing that you want to look towards. All right. So the next part is some of the things that you might see kids and what they put in their mouths. So iron, a lot of kids sometimes they eat grandma's iron supplements or things like that. When they present to you, they might have been feeling fine for the first few hours, but then they get very, very sick and actually can cause liver failure too. And you can, on an x-ray, you can actually see all these iron pill fragments in the belly just sitting there. What's important here to ask is what kind of iron is it? It seems like a really specific point, but we're looking for the elemental iron, which is basically the pure iron that they're getting, and we need to know how much of it. So if you can ask them, when did you take it? Like we always said, that history is important, but in particular for iron, being able to bring us the bottle so we can figure out what kind of iron it is. So obviously I don't expect you guys to know the numbers, sulfate 20%, fumarate 33%, gluconate 12%. But if you're able to tell us what kind of iron it is or bring that bottle in, that's going to be super helpful for us to calculate. Lead poisoning. So this is usually gradual, insidious. Family moves into an old home. Kids been running around. They love putting stuff in their mouth. They've been eating something that tastes good or funny. And it's lead chips. So typically they'll just be having this insidious change in their mentation. Kids might be complaining of headaches. There's not much to do for you guys, but just to say, hey, did you guys just move in? How old is this house? You notice any chips coming off or anything like that. So you want to always be on the lookout for leg toxicity in kids that just aren't acting right, that have been acting worse and worse for quite a while. So acids and bases, and in fact, a lot of these things for any sort of exposure, you guys show up to a fire, you guys show up to a silo or something, you guys got to protect yourself first and foremost. You've got a patient, but you never want yourself to become a patient. So you always wear protection first. We can't have more people that are sick. And the second thing is always to decontaminate those patients as much as possible, especially before they come into the ED. We don't want any of the other chemicals getting in to hurting ourselves, hurting you guys, hurting other patients. So decontamination is incredibly important. So acids and bases, sometimes kids get into the bleach. Sometimes they get into some acid, at some labs or something. What's worse, acid or base? So the answer is that it's actually bases that are worse, like industrial bleach, things like that. And it's because they cause this thing called liquefactive necrosis. And it destroys the tissue much more than acids. Acids cause burns and they hurt, but the bases actually do a lot of destruction. And part of the reason is because it's lipophilic, which means that it likes fat, so it goes into all those layers of fat that we have protecting us, and goes deep into the body. So those bases are very, very bad. So you show up to somewhere, chemical plant or something, there's an exposure, what can you do? Well, one of my attendings would always say, for anything, dilution is the solution to pollution. So you just flood that area with water, tons and tons of water. You're not going to check the pH out in the rig or anything, but you're not trying to correct the pH by saying, oh, it's a base, I'm going to give acid to try and correct it. This isn't chemistry class. You just flood it with water, normal water, and then we can check the pH in the emergency department. So a lot of times, especially when we see kids, maybe some kid accidentally got into some bleach, drank a little bit of it. How bad is that? The truth is that household bleach is not that alkalotic, and it doesn't cause that much damage. But the concern is that some of the chloride gas in it, as well as if they aspirate and vomit, goes into the lungs, and that can cause a lot of damage. So the burning itself from household bleach is not that bad, but the actual gas in there going into the lungs, if they throw up and it goes into the lungs, that's going to hurt you real bad. So as far as the corrosiveness of just regular household stuff, it's usually, we see the patient, we do like an oral challenge, make sure that they can drink and swallow and that they're doing okay in the emergency department, then they get to go home. But if mom's like, then he threw up and now he's having respiratory distress, you're looking at those ABCs. That's what's important. So right here, this is just the last slide that I have now, just for you guys to kind of approach anything with toxidromes, and you guys can review this yourself. We've gone through quite a bit of this, and this kind of gives you a flow sheet to kind of ask yourself what to think about first. Is the patient hyperthermic? Are they hot? Yes or no? So then if it's yes, then we can think about, anticholinergic syndrome or maybe sympathomimetics. But then to differentiate those, like I said, are they sweaty? If they're sweaty, then you can think about sympathomimetics like cocaine. You can think of amphetamines versus the anticholinergics. Do they have that muscle rigidity, or do they have that clonus, which I said is not really something to worry about? But you can give them benzos because, like I said, the treatment for both of those is very similar. If they're not hyperthermic, they're not having a really high temperature, are they agitated, Are they crazy superhuman strength? Could be PCP cocaine. Or history of substance abuse. And then sedation, like I talked about, meiosis, pinpoint pupils, opioids. No meiosis. Could be something else, like ETOH. And then fluids coming everywhere, possibly cholinergics, in which case you use atropine or 2-PAM until those fluids stop spewing from every single hole. And then you can bring them to us. All right, that's about all I have now. Thanks for listening in, tuning in, guys. And hopefully I'll see you guys out there. Thanks for all the hard work you guys do. Really appreciate you guys always helping us out. All right, so questions. For atropine, that's about right, 2 to 5 minutes. You don't want to flood them with atropine. You kind of see how they respond, and then you can do 2 to 5 minutes. I would give them about 2 milligrams of atropine. All right, so questions. For atropine, that's about right, 2 to 5 minutes. You don't want to flood them with atropine. You kind of see how they respond, and then you can do 2 to 5 minutes.
Our local hospitals have the capabilities of handling cyanide poisonings?
So there was another question about local hospitals managing cyanide poisoning. Unfortunately, I'm not super familiar with that. Might want to check with your chief or commander, as well as hospital staff. Unfortunately, I'm not super sure on that, but I mean, all the ED physicians are supposed to be trained with how to manage cyanide poisoning, so I think it really is just dependent on the hospital. I especially can't speak for Mercy because I don't work there. I'm just a resident at Freeman, so I know that we could probably take care of it.
Conversation.
Yeah. Okay, so I have a couple of questions as regards to, I know I have several of our fire stations currently listening and standing by as it pertains to hazardous materials, because we deal with all kinds of stuff. And it was actually very interesting conversation, so thank you. You know, we do things like we monitor gas levels for rehab at or excuse me, for overhaul at post-fire incidents. So we, per policy and FPA, are required to wear air packs in immediately dangerous to life and health environments for structure fires. However, the point gets there to where, you know, one, the air packs are a little bit cumbersome, so we want to shed them, but we don't want to shed them too early to get into an atmosphere that's unsafe. And so we monitor for HCN, we monitor for CO, and our goal is to make and we meet the OSHA requirements for those gas levels. But what we've seen is, like firefighters in general, we have on our trucks, we have rainbow mouse to most sensors, so we can monitor CO and blood gas. And we see actually CO retention in firefighters, where a normal adult is 0 to 2. We're seeing 4 to 6 to even 8 several days after a structure fire, even with all their PPE and everything affected. Is there anything that you would recommend as far as treatment outside of just, you know, high flow 100% oxygen for like CO, or even you know, things to look for our guys in rehab, to be looking for, hey, we may want to monitor this or monitor that? I know it's kind of a wide open question.
So there's actually levels for like carbon monoxide toxicity. So anything above like 25 or 20 in a pregnant lady is concerning. And obviously you're exposed, but as long as that exposure isn't that bad, I think, you know, recommending them to use high flow oxygen for a little bit can improve it. Typically we monitor them in like for 6 hours in the emergency department if it's not toxic level. I don't know if you guys can give them actual high flow oxygen or something like that.
Yeah, absolutely. We could do that on scene, but that brings up a great point, because we talk about what is considered that toxic level, and at what point in time should we say, you know, this member may need to go for evaluation. You know, obviously they could be having headaches at some point in time, but is 25 a kind of a good magic number to look at?
Yeah, so my understanding is that it's 25, or if they're a pregnant lady, it's much lower, so it's 20.
Okay.
So, yeah.
Excellent. Man, I appreciate your time, and I know it's very interesting because we deal with a lot of these different chemical, especially in hazmat.
Yeah.
So we appreciate it very much. Thank you, sir.
Yeah, thank you for having me.
All right, folks, take a break. We'll be back in a few minutes. Thanks. Bye.